All right, can you all hear me? Audio's good? Okay, a couple announcements, some housekeeping stuff. So, there's been a number of announcements from the SI and the TAs about study guides, review sheets, study sessions. Are you all getting those messages? Okay. Is it a little overwhelming? Okay, perfect. That's what we're hoping for. The last thing I want is there are no resources other than going to class. And Keller is so boring. I'm kind of being silly, but I'm sort of being real. I want to make sure you all understand that there's a lot of resources available. Let's walk through them. You have a classic textbook, okay? Some of you are like, I don't like the textbook. Guess what? Some people learn by reading. That might not be you. I get that. Some people need to be entertained. That's why we have 3 jokes. Entertainment ends in 30 seconds. Some of you want a regular lecture. I get it. Some of you don't. Some of you don't want the reading. Who wants an exam? Who literally wants an exam next Monday? That's what I thought. I'll get that feedback. This class would be great if there were no exams. I just don't know how that's possible, to be honest, okay? And the future that you're all headed towards, exams are going to be necessary. So it's good to practice. You have 5 practices, 5 exams. We dropped the lowest. Your first exam is when? A week from today. Where? Right here. Here's what it's going to look like. We'll talk about it again on Wednesday. It looks like everyone's coming to class. Most everyone's coming to class. I kind of hinted it's a good week to come this week, not just today. I would come Wednesday as well. And you'll understand, because you say there's participation points. How do you know if we're here? We're not taking roll. We don't have time for that. But there are opportunities that you only get when you come to class. Point opportunities, okay? Exam, 50 multiple choice questions. You'll get a test packet. It's going to be different than the person's test packet next to you, or a crowded room. You have a Scantron. You need to bring a number 2 pencil. I'll have some extra pencils, most likely. We'll have extra Scantrons. We'll have extra packets if you have a fit of rage and tear it up, okay? If you sit in the back row, I've already talked to you, unless you just came in. We don't have any back row seating during exams. So you got to find a seat. There's still some seats up front. So try to fill in. There's 2 prime high dollar value seats right here, like Super Bowl seats right here. 2, 3, 4, 5 in the second row. 6, 7, 8, 9. It's like the whole back row. There's 9 seats in the second row. It's to turn your ball cap backwards or take it off. No music, no AirPods. Turn your phone off. I'm hoping that your phone's off during class. I haven't heard any eruptions, but during the exam, turn your phone to silence or do not disturb. Any questions on the format of the exam? One more thing. We will have images on the screen for the last 5 questions that rotate. The questions will be in your test packet. The images will be on the screen. Those images should look familiar. They'll be images that we've covered in lecture. Another reason to come to lecture and study your lecture notes. They could be chemical structures. They could be a question about what happens to a cell when you put it in different conditions. Pictures of those. It could be pictures of histology that we're going to cover today and Wednesday. You with me? But they won't be obscure questions. They'll be, if you're attending and you're studying this week and over the weekend, those images should look familiar. And the questions that I write for the exam are not from a test bank. They're my exam questions. So they could be bad. And so you can come and challenge them. But I write them from the lectures. And when I write my exams, I try to look at my lectures. That's one of the reasons I started recording, is to remember what I talked about. Because I've taught this class many, many times over the years. And have you ever had those professors like, oh, we covered that in class? And you're like, we did not cover that. And everybody that you talk to in your study groups, like, I think he's thinking of last semester. He's really old and he doesn't remember, right? So I like to have a documentation of what I did cover for both of us. So if you're rewatching the lectures, that's a great way to study. And if I make a mistake, like I'm about to tell you right now, it was someone over here that got it right. Because I watched my lecture and I thought, on the drive home, I said, I think I might have said that wrong. I watched the lecture and I said it wrong. In electron transport chain, what is the final electron acceptor? Who said it over here? Wednesday. What's the final electron acceptor? You all remember? Water is what I said. And someone over here said, oxygen. Was it you? And you were right, and I was wrong. Okay, and I looked at my lecture, and I'm like, I can't believe I said water. Because I was talking about hydration levels, right? Water's not the final electron acceptor. So there's a perfect example. I'm not perfect. I make mistakes. We look at the lecture. I write a bad question. That's a great way to kind of cooperate. You all with me? Okay. Study guides, TA review sessions, exam one details. Okay, next ones are for later. And now we're up with, why do fathers take an extra pair of socks when they go golfing? In case they get a hole in one. Wow, who said that? Who? Very well done. Very well done. What do a tick and the Eiffel Tower have in common? Anyone? Any French folks here? I'm not picking on French folks about the tick. It's the Eiffel Tower. They're both parasites. Oh, come on. I thought that one was pretty good. What do you call a fish wearing a bow tie? Sophisticated. Nice. Wow, you're 2 for 2. I think you're ready for the exam, young man. I think you're ready for the exam. Okay. Questions about anything before we dive straight into material for today? We good? You might have more questions about the exam. We're going to have some opportunities for participation points, okay? One of them's today. So I'm glad you're here, but you got to stay the whole time. And we're going to roll out some information. I'll put it on the announcements. The TAs, the SI, and I are going to get together, and we're going to determine the number of participation points if you attend a couple of review sessions for the exam. It's that simple. That's why there's so many options. Because I know you're like, oh my gosh, I got to go to a review session? Lame. I work. I have a life. I take other classes, right? It doesn't work with my Zen. Okay, they're not that many points. Maybe you just ace the exam, you don't even need them. But some of you are looking for as many point opportunities as you can get. And what the data shows in education is the more you spend time with the material that you're trying to learn, the better you learn it. It's that simple. That's why I want you to come to class. Yeah, I record the lectures, but watching the lectures, anybody rewatching the lectures yet? Okay. How is that? Is that helpful? Is it helping to sink in? I know after a while, like at the end of the semester, like, I cannot stand the sound of his voice, right? You get so sick of it, and I'm sorry about that. But if it's a study tool and it works for you, it's repetition. It's that repetition. And that's what it takes for this class. There's a lot of Latin. There's a lot of mechanistic science. Same with lab. A lot of it's rote memorization. So the more you spend time with this material, the better you'll understand it. And if you can understand how it works and how it fits together, like today we're going to talk about histology and tissues. You could approach it 2 ways. You can just try to memorize it, and maybe that's you. Maybe you have a photographic memory. Or maybe you need to think of ways to make some connections of, okay, maybe it's structured this way because it has a purpose. Maybe the epithelium is on the outside or an air-facing surface because it has a reason for that. And so you'll see that the structure, the architecture, helps to perform the function of the tissue. And if you think about that theme as you study this chapter 4, and this corresponds to your textbook. And I've heard a couple comments like, I don't feel like the textbook and your lectures are coinciding. Well, they do coincide. They maybe emphasize slightly different material. They present it in maybe a little different order or different format because I didn't author this textbook. But that's okay. That's not a bad thing. Getting a diverse viewpoint on a topic is kind of what education's about. You all with me? Like, that's why we're here, is to expand the way we think about things and not just be narrow-minded. We try to challenge the status quo. And so by having authors that are different than your professor isn't a bad thing. And are they going to say everything the way I would say it? No. But that's actually part of the beauty. And if you understand sort of some of these connections like structure dictates function or the architecture has a purpose, there's a reason for it. It was designed intentionally for that to actually take place. And if it was designed differently, it'd have a different function. And that's kind of what we're going to see today as we walk our way through epithelium and connective tissue. First up, let's talk about histology. Where are you in lab? Connect me with where you're in lab. Have you guys already gotten the microscopes out? Not yet. What's that? This week you're in the microscopes. Okay, this is perfect. So you're going to hear a little bit about histology, then you're going to go do the histology in lab. Right? And lab and lecture are going to do that. We're going to get a little ahead. Lab will catch up. Lab will reach out ahead. We'll catch up. They're not going to be perfect in sync, just like the textbook and lecture. But they're going to be somewhat coordinated, if you will. So histology is the study of microscopic anatomy. That's all it is. And what is anatomy? What was the definition of anatomy? Study of what? Structure, thank you. What was the definition of physiology? The function. Structure and function. They're actually linked. The structure dictates the function. The architecture, the way it's shaped, helps to give rise to what it does. So if we look at the microscopy or the microanatomy of tissues, we can get insight into some of its purposes or its physiologic function based upon the way it's organized or structured. That's why we care. That's the whole reason we look. Is if it has ciliated epithelium, little hairs, well, the hairs serve a purpose. Isn't it kind of crazy that a cell has a little hair on top of it? But it's not crazy if it's found in your respiratory epithelium, and every time you cough, it helps to bring up mucus and clear out the airways so that dust and debris doesn't sit in your lungs. And you all know, because you've had infections in your chest, bronchitis, pneumonia. Any asthmatics in the room? Raise your hand. Right? You know when you have kind of that wheeze, and then you have to take a bronchodilator or a nebulizer, and it loosens up the chest, and you cough, and stuff comes up, and now it's called a productive cough, and you're like celebrating, because you know if it stays in the chest and becomes infected, that leads to bigger problems. That's why you have ciliated epithelium. Does that make sense? Just this little analogy of what are the if you see something under the microscope, and you make an observation, and it's different than another tissue that you looked at, there's probably a reason for it. The collection of cells performing the same function as a tissue. And then the organ is a collection of two or more tissues that work together to perform a task. Up top, upper right, we have pseudostratified ciliated columnar epithelium. You'll learn about it this week in lab. But it's just like I talked about. It's ciliated that forms a purpose by allowing for the movement of debris. The lower right is a very different kind of cell. This is, anybody? Guess? What is that a picture of the lower right? It's a neuron. A big old fat cell. These guys are narrow and in columns. That's why we call them columnar. They're pseudostratified, pseudo meaning fake. It's not multiple layers. Stratified means multiple layers. It's actually a single layer, but because some are skinny and some are wider, it has the appearance that the nuclei are in different levels of pseudostratified columnar epithelium that's ciliated. That's a mouthful, but it tells you a lot of the characteristics about the tissue. So 4 different types of tissue. If we look at the far left of the slide, we see where they come from the embryo. We have a mesenchymal layer, which is a middle layer, and we have the epithelia layer, which is an outer layer. The mesenchymal layer comes from the mesoderm. The outer layer comes from the ectoderm. There's a third layer known as the endoderm that's not on this particular slide because it actually gives rise to inside parts, if you will. But you can see that in the adult, the epithelia gives rise to epithelia and nervous tissue, which gives rise to the lining of body cavities and coverings, like skin and the intestines. Nervous tissue, obviously brain and spinal cord. Our mesenchyme, or our middle layer from the mesoderm, gives rise to muscle for movement and connective tissue for bones and tendons and support. We're going to look today at epithelium and connective tissue, the top and the bottom boxes. Histology. When you view histology this week in lab, I want you to appreciate a few things. It can be very deceiving. So, for example, you have to think about the orientation of what you're looking at. You take a biopsy from someone's skin because you have a suspicious lesion. You have a mole that's irregular. It's raised. It's irritated now. Last week, the mole was a nice round circle, and it's been like that for years since you were a kid. All of a sudden this week, it looks different. It has bumps on it now. It's irregular. It's not round. Jagged edge. So you take a biopsy, you send it to the pathology lab, and they dehydrate it. That's what they do first. Take all the water out. Then they infiltrate it with wax, called paraffin wax. And now it's completely dehydrated, infiltrated with wax, and they put it in a block of wax, and then you can slice it in very thin sections and put it on a glass microscope slide that you're going to look at in lab this week. What color is that tissue when you get a slice of that tissue on a microscope slide? What color is it? What color do you think? Let's say I say it came from your skin. What color do you think it is? You took the glass and you looked at it, shine light through it, or you stick it on the microscope, you shine light through it. What color is it? Any guesses? Pinkish, purple. Okay. Clear? Why do you say clear? I don't know. It's a good guess. It's a really good guess because she's right. I was going to start going down this pathway of what happens if it's my skin versus someone who's more fair or someone who has darker skin? It's all clear. It doesn't matter what color your skin is, even though it came from skin. You're like, what? We'll get there here in a second. But now let's talk about the orientation. I'll talk about the coloration of skin and tissues, but it is clear. The answer to that question in class and on any subsequent exam or participation points is that tissue before you stain it is clear. Before you stain it, it's clear. So now let's consider this piece of tissue or this noodle that you've embedded. If you slice it in different locations, do you see how this dotted line is telling you, I'm slicing this noodle here at this red dotted line, and this is what I see. I see 2 holes. If I slice it a little further down on this green dotted line, I see this from the top view. Are you with me? If I slice it a little bit lower in the blue dotted line and I look down, I see that. I see an oval. So depending upon where you are when you section that piece of tissue, you're going to get very different perspectives. So typically what we do is we do serial sections. We slice all the way through. We lay this all the way out, and the pathologist scans the entire serial section of the tissue to determine the pathology of the lesion. Is the mole cancerous or not? Is it benign or is it malignant? Same kind of example over here. If you slice through this thing, you're going to get very different shapes depending upon where you are in the depth. Does that concept make sense? Stains. After you take the tissue, which is clear, we subject it to numerous different stains to highlight certain features. And that's kind of the art, if you will, of histology. Across the bottom, any guesses what that's histology of? These 4 panels across the bottom. Any guesses of the type of tissue? Cartilage. They're all 4 different stains of the same tissue, hyaline cartilage. Hyaline cartilage is found lining the trachea to keep it from collapsing. But you can see, depending upon what stain you select, you're going to get very different images. Okay, we already answered this question. What color is any tissue? I like to use skin because it's the one you can see, and it usually has some sort of color to it, right? Or we think it does. But when you take a piece of skin, unstained except for the nuclei are stained in this particular sample, this is the epithelium up top, this is the dermis down low, this is the interface, kind of this architecture is the interface called the rete peg between the skin layers, the dermis and the epidermis. And the nuclei have a nuclear DAPI stain, so you can see them as blue. But the skin tissue itself, the deep skin tissue and the superficial skin tissue is clear. Except for any other colorations that you can see. There's some brown. That's actually a protein known as melanin, made by melanocytes that gives our skin its pigment. So if you're more fair complected, you have less melanocyte production, or melanin production from the melanocytes. If you're darker skin complected, you have more melanin. But you can see that it's in very specific areas. Kind of interesting, right? If we stain this, which is the most common stain known as hematoxylin niacin, every ethnic type of skin looks pretty much the same because the pink and the purple dominate any melanin that's able to be seen. So this is the clear tissue. This is after a stain. Same tissue, skin. This is the epidermis up top. This is a stratum lucidum layer that you'll learn about in lab this week. This is our dermis down low. This is that interface, that rete peg interface that we were talking about. Okay? So just some characteristics of tissue. Now, let's dive into epithelial tissue first. So we're going to talk about features and characteristics of epithelium. Think skin. Think body coverings and openings in the mouth. Okay? Digestive tract, the GI tract. So we've got functions of these types of tissues and locations. Think about where they are. Well, you're going to have protection because you're talking about skin and respiratory tract. These are interfacing with the outside environment. A barrier to keep certain things from coming in. Also to keep certain things from leaving, like water. So if you have a burn patient, many of you that raised your hand, how many future nurses in the room? And PAs? And keep them all up. And physicians. And PTs. Okay, that's a lot. Not that anybody outside that category wouldn't be dealing with severe burn patients, but you get a patient that comes in with burns. What's the number one first problem you're worried about with like 70-degree burns of the skin? Number one concern you have clinically. That's actually number 2 is dehydration. First, so that you answer the second question first, what's the first thing you worry about? Infection. Okay? So infection is keeping bugs from coming in, bacteria, and dehydration is preventing water from leaving, right? We're 50 to 75% water. And you remember osmosis and diffusion? If you have a high concentration of water here and you have low concentration in Arizona, because it's an arid environment, you're going to lose a lot of water pretty quick. You with me? Absorption. Functions in the small intestine. Secretion, the kidneys and different types of glands like sweat glands. Filtration, kidneys. All different types of epithelium And because you're in different locations, you're going to have different architectures. We'll talk about transitional epithelium that's found in the bladder here in a second. Generally speaking, we say that epithelial tissue is cell-rich and matrix-poor. If you look at the ratio between cells to matrix, there's a lot of cells and there's less matrix. We have structures known as tight and adhering junctions. We refer to these as desmosomes that actually connect one cell to another. You can imagine in the skin, if you don't want to lose water, you can't have cells that are really far apart. Does that make sense? You need those cells to be very closely connected with adhering junctions, or what we refer to as tight junctions, desmosomes. They're relatively avascular, the epithelial tissue. Relatively avascular because you actually don't have a lot of space for blood vessels. So the vessels are found in the underlying epithelium. So like in the skin, for example, the highly vascularized tissue is the dermis. That's the layer beneath the epidermis, which is the outer covering. In fact, do y'all remember this? Maybe, I don't know. When we were kids, we did a lot of things that, I don't know, they're probably like illegal now. But we would take straight pins and we would put them into our hand, like sideways. Do you know what I'm talking about? Like just on the very surface. And then if you're sitting next to somebody you really liked, you'd be like, ah, right, and try to freak them out. And it didn't hurt. And it didn't bleed because the top layer of the skin is avascular. There's no nerves, and it's mostly dead cells that slough off. So most of these epithelial layers are for protection. You don't have a lot of vascular elements. You have vascular elements, the tissue adjacent to it beneath, and oxygen gets to the superficial tissue through diffusion. The diffusion distance of oxygen happens to be about 200 to 250 microns in tissue. So as long as you're not any further away from there, you won't have necrotic tissue. They're sided, or what we call polarized. There's a basal side, which is the basement. Think about basal, like the word base looks to be in there. And then we have the apical side that faces out, or the lumen. The basal side is supported by connective tissue that holds it together to the basement membrane. The apical luminal side is the site of secretion. The apical side of the skin is the outside side of the skin. The apical side in your small intestine is the side that faces the lumen, where the food is actually located. Right? I mean, this is kind of a mind-blowing concept, but in the GI tract, when you bring food in and consume it and swallow it, and it moves through the alimentary canal before you excrete it, it's always part of the outside environment until you absorb the nutrition across the basement membrane. You with me? Okay. The apical side, this is a place where we have a lot of secretion, or we have the ability for exocrine release or endocrine release. The two different terms, exo has the X in it, like exiting the body. So you release it outside of the body or onto a luminal surface, exocrine. So any digestive enzymes that you release into the stomach or you release into the small intestine, you're actually technically exocrine, releasing it outside of the body into the lumen. Make sense? Whereas endocrine is when you release it into a duct, like the bloodstream. Endocrine is for like hormonal release, very different than exocrine. Hormonal release to regulate metabolic rates, regulate sexual development, regulate circadian rhythms. Hormonal release is very different than exocrine release. But both of those cell types have an epithelial layer. Rapid cell division. So your skin itself is kind of the main example that I use when we talk about epithelium. The skin turns over about every 6 to 8 weeks. We're going to have an integument system lecture after Unit 1. So a lot of skin won't be on Unit 1, the exam on Monday. It'll be on Exam 2. We'll talk about the skin and the skeletal system for Exam 2. But we're setting the stage. I had one of your classmates ask me, like, are we going to get into like anatomy stuff, or are we just talking about all this basic background stuff? Hopefully you can kind of see the progression of the story. I'm trying to remind you of what you already know, refresh it, and then start making applications and connections. We're kind of connecting a little bit to organ systems today and Wednesday. And then exam 2, 3, 4, and 5 is all about the organ systems that we're in for that unit. And if you look at the syllabus, it's organized that way. It's very intentional. So the skin, you can see down here on the lower right, the bottom of the foot, and this is a section of the bottom of the foot, that histology, hematoxylin eosin stained histology. You can identify it by the pink and the purple. This is the apical side. This is the side that turns over and sloughs off. And all of you can do this experiment, right? Especially in Flagstaff right now. You can do this, and you can kind of see, if you go like that, you'll see, especially on like a dark surface, you'll see flakes of stratum corneum coming off of your skin. Because the basal layer down here, the basal side, is the regenerative layer. That's the side that actually divides and turns over, and those cells move from the basement and they move up towards the apical side. And it takes about 6 to 8 weeks to do that. And as they move towards the surface, they slowly die. They get further and further away from a vascular supply. They package up their organelles. They excrete their nucleus. And they become a dead cell that's like a corny or a horny layer. Now, those words are very important in the Latin, because they're the same thing that happens for nails, hair, in other species for horns, right? Those are dead layers of essentially skin that are sloughing off. And that's why, any hunters in the room? Anybody hunter, like big game hunter? Okay. Nobody kills animals. All vegetarians. Gotcha. So you can go looking at certain times of the year for sheds, right? You find them because the animals drop them. Just like you shed your skin. Or you look at other organisms like reptiles that do it all in one sitting. Instead of molting and leaving, I think this would be really gross, right? If half the class was molting right now, and then at the end of the lecture, I just look and there's dead sleeves of skin laying over the nice new blue chairs. That would be so disgusting. I'm so glad that you all just leave a little bit of you behind that we can't really tell. But it's still equally gross if you think about it, right? Yeah, so don't lick the chair. Rapid cell division, constant turnover every 6 to 8 weeks. Different types of epithelial cells. We've got pseudostratified. It's always ciliated. We've got transitional. As we've talked about simple, we talked about, did we talk about simple? Oh, let's go back here. Let me go back to this one. So simple, one layer. Simple squamous. Squamous means flattened. Simple cuboidal. One layer looks like a cube. Simple columnar. One layer looks like a column. Pretty easy. Stratified, multiple layers. Stratified squamous is the top layer of the skin. Multiple layers of flat. Stratified cuboidal. Multiple layers of cubes. Pseudostratified columnar. It's actually, all of these cells touch the basement membrane, but some of them look like they're at different levels because the nuclei are at different levels, depending upon where you slice the tissue. And then transitional. Transitional has the ability to stretch. You find it mostly in the bladder. That's the best example. All right, so I skipped that part. So let's talk about pseudostratified and transitional, because these are kind of the other categories. So that should be a little bit more obvious, or understanding be a little bit easier now. These are kind of non-standard types of epithelium. Pseudostratified we've covered, but it secretes mucus, and the cilia helps sweep it away. We call this the respiratory escalator, like when you cough and you bring up a little bit of mucus. Every time you cough, a little bit of mucus comes up. Okay, but typically, because it's not socially acceptable just to hawk a loogie anywhere you are, you actually just swallow it. Yeah, you do. Okay, you just don't notice it. Don't worry, it passes right through. You notice it when the amount of mucus is excessive during a cold, and then you're more discreet. You carry like a napkin or a Kleenex with you, or you go to the restroom or whatever. Okay, but you all have experienced it. This is real stuff. Cigarette smoke and a lot of the toxins within tobacco actually poison these cilia. And so patients that are chronic smokers for many, many years, that respiratory escalator gets poisoned, and it doesn't work. So they always have a raspy kind of cough that nothing ever comes up. So it leads to a lot of bronchitis and infections in chronic smokers. Transitional epithelium. Transitional epithelium, you can see they're a little bit more cuboidal in appearance when the bladder's empty. They're a little bit wider, and as the bladder stretches, they flatten out and become more stratified or flattened in appearance. So they transition from a cuboidal-like shape to a squamous-like shape. And thank goodness they do, because you're on a long road trip, you're like, next rest stop, 67 miles. You're like, crap, right? So usually the example that we show is in the bladder, and you can see at the tips of all of these locations a collection of this transitional epithelium that moves from cuboidal to squamous-like. Functions of simple pseudostratified and stratified. As we finish out epithelium, and then we're going to shift into connective tissue. So simple functions: absorption, secretion, diffusion. Does that make sense? If a simple tissue is one cell layer thick, it helps to facilitate secreting something out or absorbing something in. Pretty obvious. You don't want a really thick layer of cells if you're trying to absorb something or to secrete something. Simple squamous, simple cuboidal, or simple columnar. Lining different structures that we've talked about, like digestive tract, the kidneys, and skin. So on this particular slide, and here's a perfect example of the types of images you might see on, say, a bonus assignment, or a participation activity, or an exam like next Monday. The type of histo that I show here, if you're attending lecture, if you're rewatching the lectures, you'll say, I do remember that histology. Okay? And we have record of it. It's not like I'm going to put some random slide that you've never seen. Okay? I'm not trying to intentionally trick you. Lower left. Simple squamous in a blood vessel. These are endothelial cells. So do you see how this cell and this cell are flat like pancakes versus the cell that's out in the tissue that's a little bit more rounded? So in an endothelial cell that lines the blood vessels, if those blood vessels are in the intestinal mucosa, you're trying to absorb nutrition into the bloodstream so that you can bring sugar, for example, to tissues and then pull it out of the bloodstream into the cell for energy utilization through glycolysis and subsequently aerobic respiration. Do you remember that? Now let's review. If we go through glycolysis, one sugar molecule that we've absorbed into the bloodstream, how many ATP do we net from the glycolysis pathway? 2. Very good. If we just think about aerobic respiration, which is the Krebs cycle and electron transport chain, final electron acceptor is oxygen. Thank you for correcting me. How many do we net from those two processes? 36. Pulling from the bloodstream. Middle picture, simple cuboidal epithelium in the kidneys. What do the kidneys do? Filtration. So you bring fluid. In fact, the kidneys themselves come right, you'll learn this in 202, but the heart pumps blood to the aorta. Down the descending aorta, like the first structures that get blood are the heart and then the brain. Then the next structures that get the blood are the kidneys. So about 30% of cardiac output, all of the blood that you make that comes out of the heart, 30% of it goes straight to the kidneys instantaneously to be filtered. You're filtering particulates. You're filtering metabolic processes. You're filtering high pH, low pH, right? These are filters. Anybody ever changed a filter, like an oil filter or an air filter, like a filter in your apartment? You know, and you've gone a long time, and your landlord's like, could you change the air filter, you know, in your apartment? You're like, yeah, and you look at it, and you're like, it doesn't look that bad, but then you get a new one from Home Depot, and you set it side by side. You're like, holy crap, I am disgusting. I am so dirty, right? Don't worry, it's all skin cells in the filter, pretty much. So these filter the blood and allow you to actually have clean, homeostatic norm fluid in your body. Dialysis patients. What is kidney dialysis? Anybody know what that is? Someone has a loved one, a friend, or you just know about it? Some kind of know in the back. Tell me what you know about kidney dialysis. Let me pose it this way. If your kidneys aren't functioning, is it a big deal? Well, you've got two of them. It's a big deal. So tell us a little bit about kidney dialysis. Over here in the maroon. And how frequently do you have to have it filtered because the kidneys aren't working? Usually 3 times a week. You go into a dialysis clinic, you sit in a chair, they pull the blood out of your arm, put it through a machine, filter it, and then put it back in your body. That's what your kidneys do sitting right here. Very convenient, right? Really, really important for renal function. Cuboidal, simple cuboidal epithelium. Far right, these are pseudostratified columnar epithelium. Where do you think this is found? We've talked about it. Lungs. You all could explain what it does, right? Helps to move debris out of your lungs. Okay, let's look at stratified epithelium. Skin, mouth, esophagus, anus, vagina. Protection, right? Anytime there's going to be abrasion that takes place. You know, think about your esophagus, the foods that you eat. Have you ever, been talking and you're chewing and you're having fun with your friends and you take a drink and then you swallow and you're like, oh, and there's this monster pain because it feels like something stabbing you in your chest because that chip you didn't quite chew enough? Aren't you glad you have stratified squamous, right? So any place in the body where you need protection. The basal side is the regenerative side, just like the skin. So the GI tract and the skin regenerate very quickly. Unless you have a patient that's wrestling with a GI abnormality, like Crohn's disease or IBS, something that's an underlying chronic inflammation of the intestinal lining, then this layer might turn over more quickly. And the problem with higher turnover of tissues, especially if there's irritation in that area, now you're susceptible to what? You're susceptible to mutation of that metabolic layer, and that's where you increase your risk of developing a cancer in that particular tissue. Okay? That's why sun damage on skin, right, causes excessive inflammation and irritation. Again and again, repeat injury, again and again and again. You're at higher risk of skin cancer. Unmanaged, uncontrolled, like IBS, Crohn's disease, you're at higher risk of developing colon cancer or GI cancers. The apical sides die off and slough off. That's true in the gut. That's true in the mouth. That's true in the skin as well. The images, left, pseudostratified epithelium. Again, you can see the cilia in this picture much better than you can see the cilia here. You have to look really carefully to see kind of the little hairs, but here it's zoomed into a higher magnification, and you can kind of appreciate that. Pseudostratified epithelium in the middle, stratified squamous on the far right. Questions about epithelium? Remember that table I showed you in the very beginning? And said we were talking about the first box and the last box. So the last box is connective tissue. What does connective tissue do? It actually binds things together. It connects things. Sometimes scientists aren't all that creative. We call it connective tissue because it holds things together. It's determined by the cell and the matrix types. It's the glue that holds us together. It binds things together, connects bones to bones. What are structures that connect bones to bones called? Ligaments. What about muscles to bones? Tendons. Very good. It binds this tissue together even when it's damaged. So this picture of this individual's back, any idea what this is? What's the name for it? Cicatrization. Cicatrization. So it's a practice that actually comes from certain tribes in Africa, although intentionally cause trauma to the skin, to generate elaborate scarring in a pattern to identify who they are and who they belong to. Anybody see Black Panther? Yeah, this is Michael B. Jordan, like on his chest. Some of you are like, I remember that scene. I paused that scene. So that's cicatrization, okay? So the skin will scar as it heals, and you're going to regenerate damaged tissue to a stronger extent, to a greater extent than it was, laying down connective tissue, laying down excessive collagen. And all of you, don't start taking like clothes off and stuff to show me your scars, but all of you have scars, right? And you can look at those scars and go, oh yeah, I remember that one. And they're more pronounced as we age than they are when you're younger because your healing processes, and we'll learn more about this in skin lecture after exam 2 or after exam 1. But when you're young, your skin actually heals a lot better than when you are puberty beyond. And a lot of those early wound healing events that take place embryologically, neonatally, and in childhood, they fade by about adolescence. And so that's why scars that happen now at your age are more aggressive than they were when you were younger. But this is just a great example of the response of the skin in a damaged environment. So connective tissue, it supports, it protects. We have organ capsules. We have these capsules around our internal organs of connective tissue. How many of you have ever been in an open chest procedure? Been able to watch one? One hand? 2 hands in the back? Anybody been able to be in the OR and see intra-abdominally or intrathoracic? The first time I scrubbed in to an open chest procedure and looked into the chest cavity, you're going to do heart dissections in 202 of sheep, okay? But human hearts, what color do you think they are when you stare at them? And they're not clear. This isn't a trick question. It's not purple. It's a good guess. It's not white. It's closer, more yellow. Yeah, yellow. Because there's so much fat around our hearts as an organ capsule to create cushion. And as we age, we tend to put more fat on. We don't tend to shed fat when we get older. And so in older patients that have open chest procedures, usually it's not like a young, athletic 20-year-old that's having an open chest procedure, not normally. It's usually a 70-year-old, slightly overweight, hypertensive, needs a bypass procedure, stents aren't working, right? Probably like grandpa age for all of you. Organ capsules. That connective tissue, fat is a connective tissue. Adipose tissue is a connective tissue. Is it hydrophilic or is it hydrophobic? Is fat hydrophilic or hydrophobic? Hydrophobic. Very good. Just kind of making some connections to our first lectures. Bones, a type of connective tissue. Cushions or insulates, like you see right here, articular cartilage between the bony surfaces. We talked about adipocytes or fat cells that cushion structures like the heart and internal organs. So these connective tissues are very different in purpose. Therefore, they're very different in architecture than epithelium. The connective tissue helps to store and transport nutrients, like adipocytes for fatty acids, right? These fatty acids make up the building blocks of our membranes. We talked about that a couple lectures ago. The bone marrow, by the way, upper right is fat. Like your textbook in this chapter says it's like if you took a grouping of balloons and pushed them together, that's kind of what adipose tissue looks like. I think that's a pretty good explanation. I never would have described it that way, but I think these authors do a pretty good job. And if you're a visual person, that might be a way for you to remember, like, these look like balloons pushed together. Those do not. This looks like a sorry-ass balloon, okay? All right? So maybe that descriptor is kind of helpful. Bone marrow, bone on the lower right, gives rise to blood cells. White and red blood cells come out of the bone marrow. A lot of stem cells housed in the bone marrow. Gives rise to blood cells. Bone also stores calcium. So storing, transporting nutrients. In the skeletal system, we'll talk about these features of bone. We'll talk about how it stores calcium. We'll talk about how it stores minerals. We'll talk about how it leads and gives rise to blood elements. And over on the far right, these are blood cells, red blood cells. Very thin, long, and sort of like biconcaved. They have like a little dimple that is like a donut hole that doesn't go all the way through. Far right is marrow tissue out of the bone. Far right is marrow tissue out of the bone. In the bone, the A is labeling what looks like clusters of balloons. What are those cells? Fat, adipose tissue. There's a lot of adipose tissue in bone marrow. And then the T is labeling what we call the trabecula, or a strut of bone. So a lot of storage capacity, fat and bone. A lot of ability to transport or make readily available nutrition or nutrients. Connective tissue is considered cell poor. Epithelial tissue was called what? Cell rich. So now we're the flip opposite. We have less cells and we have more matrix, or we're matrix rich. The cells that we do have are very immature cells. We usually refer to those as blasts. Like an osteoblast is a bone cell that's a very young, immature cell. An osteocyte, the word cyte is the Latin meaning cell, like a mature cell. So an osteocyte is a mature bone cell. An osteoblast is an immature bone cell that's kind of building bone. Again, we'll talk more about that in Unit 2. The matrix itself, that's the outside component of the cell. So the way that I think about this, look at this picture. Imagine, these are illegal, I'm sure, but in the old days, we used to go to the playground as kids, and they were what we called jungle gyms, like metal structures that in Phoenix and like July, if you weren't careful, you would just burn your hands attached to it, and your mom would have to pull you off, right? So that jungle gym is what kids like climb all over. We used to have like these dome jungle gyms. Remember the dome ones? Have you ever seen those? Like these dome ones, and kids would just climb all over it. The kids are the cells, and the jungle gym is the matrix. And cells have to have something like a 7-year-old kid climbing on a jungle gym. And so you can see these collagen and elastic fibers. The collagen fibers are arrowed or pointing to the thicker pink-looking bundle. The elastic fiber is the dark, thin-looking fiber. And these extracellular matrix proteins, okay, these are proteins from lecture 1, right? Extracellular matrix proteins that the cell makes and excretes them through exocytosis into the outside environment, forming a matrix or an architecture that the cells can live within. Make sense? You never find a cell in the body all by itself. It's attached to something. It's holding on to something. In the early days of cell therapy, regenerative medicine and cell therapy, we loved to inject cells into the body. And we would do these studies and put them in the body, and we were shocked when we did this in the heart. We would inject stem cells in the heart, and on the first cardiac cycle, we would lose 95% of the bolus of cells that we injected. And we were all like, wow, that's kind of shocking. And then after a while, you're like, well, actually, that makes a lot of sense. They're not even attached. You give them no time to attach to anything. So cells have to live within a matrix environment. And you can see some cells. Do you see these dark spheres or like oval structures in this tissue? These purple nuclei, those are the center of the cells. This is areolar connective tissue. This picture, areolar connective tissue. Might be good to write that down. So the extracellular matrix is the environment that the cells live in outside of the body. Some other characteristics of connective tissue. They're typically very well vascularized. Now, epithelium, was it well vascularized or not? Was not well vascularized, epithelium. Connective tissue is typically very well vascularized, so it'll heal very quickly. There's 2 exceptions that I have listed here. Cartilage, well, 3, I guess, and tendons and ligaments. Tendons and ligaments are mostly the same. One just connects bone to bone, and the other one connects muscle to bone. But tendons, ligaments, and cartilage are very poorly vascularized. They're the exception within connective tissue. Therefore, they do not heal very well because they don't have a nutritional supply. How many of you have torn cartilage, ligament, or a tendon? Raise your hand. I've got mine up because my left one has been torn a few times. How well did it heal? 6 weeks? No. You're probably still wrestling with it if you never had surgery, right? How many have actually torn a muscle or broken a bone? Both of those are very well vascularized. How well did they heal? Complete recovery, right? Broken bone, 8 weeks later, it's like stronger than it was. The secret to healing is vascular blood supply to deliver nutrition. So cartilage, ligaments, and tendons do not heal well for your future patients. And that is the reason all of you physical therapists are going to have great jobs in the future, right? You're like, yes. So if we can figure out a way to vascularize them, you're all going to be out of a job, right? But that probably won't happen. So, well vascularized, the exception of cartilage, tendons, and ligaments, which is why they don't heal very well. The matrix components. So these matrix components are made up of a gel. And remember how we said, what was the body composition of water? How much? 50 to 75%. You think there'll be a test question on that? I've only said it like 7 times, right? Where's all that water? Are we just like a bag of water? Well, does that seem from an osmosis standpoint to be very efficient? Probably not. You'd lose it. So you have to actually bind the water somewhere. So you have what are called polysaccharides. Do you see this little like millipede-looking thing up here on the right? That's a polysaccharide. We've got a component of that polysaccharide known as a proteoglycan. If we blow up this box and that structure down here that we look at in more detail, the proteoglycan aggregate, the polysaccharide is what? It's made up of many what? Sugars. Remember that word, polysaccharide? Monosaccharides, disaccharides, polysaccharides. The polysaccharides attach to a protein core, so now we call it a proteoglycan. Proteo coming from the root of protein. This is a protein sugar or a sugar-coated protein, a proteoglycan. So a lot of these words, so some of you are like, why do we have to go through all that like background garbage? Why can't we just get in the cool stuff? Tell us more about wound healing and broken bones and how they heal. Well, but some of this terminology is really important. If I take a proteoglycan, which is a sugar chain molecule, not a monosaccharide, not a disaccharide, but a many-saccharide, I bind it to a protein. Now I have a proteoglycan. You understand the word terminology. Water is going to be attracted to it because it has a net negative charge as a protein sugar, which attracts sodium, which is negative or positively charged? Positively charged, Na+ on the periodic table. Sodium is attracted to this proteoglycan because it's negatively charged. Lots of sodium attaches to a proteoglycan. Osmosis, what does water like to do? It flows to where? Higher solute concentration. Higher concentration of sodium is going to attract the water. The proteoglycans within your tissue is why your tissues stay hydrated and you don't just lose the water. Make sense? It's just science, right? It's chemistry. But if you don't break down kind of the basics, you understand why we're looking at periodic tables and charging of molecules, and then we look at how do you structure a simple sugar to a complex sugar? How do you pair it with a protein? Now you have a proteoglycan that's negatively charged. It attracts a positive molecule like sodium. Water follows it. That's like 4 lectures that we just went through on this one slide. Are you with me? That's the secret of staying hydrated. If we didn't have these structures, these really cool-looking, funky-looking structures, we would dehydrate like that, and we would be dead. So proteoglycans, arguably, within the matrix, are the single most important structure keeping us alive. They're sponge-like. They resist compression, and they create pores and spaces. We have a tremendous amount of proteoglycan activity in our cartilage tissue. That should make sense. The cartilage is like a sponge. The matrix components. Fibrous component is what we refer to as elastin and collagen. So here on this, we're talking about collagen. Collagen is a structural protein. It's the most abundant protein in the body. About 25% of all the protein in your body is collagen. There's 20 plus collagen genes, so there's different isoforms of collagen that we've identified. We're at about like 24 and counting, because now they started going like 23A, 23B, so I don't really know exactly how many, but there's 20 plus, somewhere between 20 and 30 different forms of collagen in you and I. Collagen 1 and 3 are the most common. They're woven together in a helical format. Anybody sail or boat? No? Okay, one person. Anybody seen a boat? I know it's Flagstaff where there's not a lot of water, but okay. Let's talk about rope for a second. You take a rope and you want to make it stronger. How do you make it stronger? You get 2 more and you weave them together into 3 cords. And that's how collagen is structured, is a typical woven structural fiber. Very, very strong. Many, many collagens together are a fibril. Many, many fibrils together are bundles, and the bundles are what you see. Now, elastin. The elastin component is less common than collagen, but the second most common in the body. The elastin is thread-like. It's long. The elastin in this connective tissue is the black squiggly line by the green arrow right here. The collagen are the sort of pink, long mandrels, and reticular tissue is actually the red arrow, the very, very thin line that you see. Elastin, what it does is it allows for a recoil, a stretch and a recoil. So you've got tensile strength from collagen, then you have elastomeric capability for the skin to snap back or any tissue to snap back. So grab the back of your hand, pull it, and let it go. What does it do? It snaps right back. That's because of the elastin, and to some extent because of the proteoglycans keeping it hydrated. So if you're wanting to determine if someone's dehydrated, right, in survival classes, they'll tell you to pinch tissue and see what happens. Pinch different parts of the tissue and see if it stays depressed. That means that the patient is dehydrated. So collagen is tensile strength. Elastin is the recoil capability. So we've got different ways we can have a combination. We've got ratios. We can have more elastin than collagen. That's how you would read this. More elastin than collagen would be more elasticity of the tissue, like in skin, bones, blood vessels, heart, bladder, lots of elastin. You're like, bones? Yeah, that's why they're not brittle. That's why they give a little bit. Collagen, greater than elastin, more tensile strength. More tensile strength. If you have more gel over fibrous, you have more water content, more cushion, like you find in in cartilage. So I want you to be able to compare and contrast the first part of the lecture with the second part of the lecture. Epithelial versus connective tissue. That's what I expect of you on the exam. And hopefully, if you think about the first half of the lecture to the second half of the lecture, you can see some dramatic differences between the two. You ready to try a few? Some test-style questions. You might see something like this in a week. Picture on the slide, it's in your test packet, but the image is here saying, what is this? Show of hands. Just raise your hand when I get to the answer. Do you think this is stratified columnar epithelium? Raise your hand. Transitional epithelium, B. Simple squamous epithelium, C. Simple columnar epithelium, D. Stratified squamous epithelium, E. Okay, I think people were paying attention. E is correct. What tissue is it? Skin, very good. This one's a little bit more difficult. What is this one? Dense regular connective tissue, A. Adipose connective tissue, B. Reticular connective tissue, C. Dense irregular connective tissue, D. Areolar connective tissue, E. Okay, I see like 3 people voted. Nicely done. This is dense irregular connective tissue. Dense irregular connective tissue, D. It's dense, it's irregular because these lines are going, see this one's going sideways, this way. This one's going up this way. This one's going that way. This one's so this is dense irregular connective tissue. In lab, you're going to reinforce these things this week and next. Okay, last one. Dense regular connective tissue, A. Adipose connective tissue, B. Fibrocartilage, C. Hyaline cartilage, D. Areolar connective tissue, E. Hyaline cartilage, D. We did kind of give an example in the beginning of lecture of like 4 different pictures that look all very, very different with different coloration of stains. And this is one of those images. Hyaline cartilage. Hyaline cartilage kind of tends to have these googly eye appearances like that, kind of like fish eggs or frog eggs. Questions so far? Okay. For the next part, you all are going to want to take a picture of this next slide. And this won't be in the video. So we're going to pause for a second so I can do my fancy video editing, which is on the iPad, and cut to this frame. You ready?